Mhm. So students, today I am going to discuss colostomy. So what is colostomy? See, these colostomy, ileostomy, very important topic for your clinical examination as well. Okay. So colostomy is an artificial stoma or artificial opening made in the colon for the purpose of diverting feces and flatus on the anterior abdominal wall, which can be collected by appliance. Okay, so it's an artificial opening made in the colon for the purpose of diverting feces and flatus on the anterior abdominal wall, where it can be collected by an appliance. This is colostomy. Okay, if you do the similar thing in the ileum, we call it ileostomy. In jejunum, we will call it jejunostomy. Okay, so even in urinary tract, you divert urine to the exterior, called urostomy. So this is stoma formation. Okay, so what are the types of stoma which we make? See, it can be either a temporary stoma for some time, then it will be reverted back to normal, or it can be permanent stoma. Okay, this is one classification. Either it is temporary for some time, usually 3 months, 6 months, or it can be a permanent. Patient has lifelong will have to bear with that stoma. So it is temporary or permanent, or it can be, see, in this colon, you can either bring the proximal end, then it will be end colostomy. Okay, so one end is brought out on the anterior abdominal wall, we call it end colostomy. If a loop of the colon is brought out, we will call it loop colostomy. So in end colostomy, there will be obviously one lumen diverting feces to the exterior. In loop, you will have a two lumen. One will, proximal one will divert feces, and the distal one acts as a mucus fistula, only a little bit of mucus is secreted. Okay. Other thing is, same you can do in ileum, you can bring it as an end ileostomy, where the single lumen will be there, or a loop ileostomy. Okay. The advantage of loop ileostomy or colostomy is that when you have to close it, you can close it without opening the abdomen. Okay, from there only. So why do we make colostomy? See, the indication will be, suppose for temporary colostomy, somebody has presented to you with obstructing rectal carcinoma. Then in emergency, what we want to do, we want to divert the feces so that the patient is relieved of his obstruction. So you can make a loop colostomy in the sigmoid colon so that his obstruction is relieved, and then subsequently you will deal with the rectal carcinoma. So relieve the distal obstruction by doing a colostomy. Either if you do, it can be again end colostomy or loop colostomy. Okay. Another indication will be to protect an anastomosis distally. Suppose you have done distal end-to-end anastomosis and you are worried that this might not be a good anastomosis, it might leak. So what you do is you divert the feces to exterior, okay, to give rest and time for the distal anastomosis to heal. Okay. Colostomy, permanent colostomy is done for, suppose after abdominoperineal resection, when you have resected anal canal, sphincter and all, as in carcinoma of the lower rectum and anal canal, that operation is done in abdominoperineal resection. In that case, the patient will have a permanent end sigmoid or descending colon colostomy. That's an indication for permanent colostomy. Permanent ileostomy is made when you have done total proctocolectomy. The patient can have a permanent end ileostomy. And temporary, as I said, it will be done for diversion of, to relieve the obstruction, or for to protect an anastomosis. Okay, or if suppose you have operated on a patient with gangrene, intestinal gangrene is there because of obstruction and all, and patient's condition is not good enough for anastomosis. In those cases, we resect the gangrenous part and bring out the proximal part as a ileostomy or colostomy and close the distal stem. okay, and so as a temporary stoma formation. So where do we make colostomy? Actually, colostomy is most of the time done in the left iliac fossa, both sigmoid colon, ascending colon, sometimes in transverse colon also. Okay. Usually a 2-3 centimeter skin, circular skin patch is excised. Then you get subcutaneous tissue. Beneath that is anterior rectus sheath. A cruciate incision is given on the anterior rectus sheath. Then when you cut the anterior rectus sheath, the next structure will be rectus abdominis muscle. We split it. Behind that is fascia transversalis and peritoneum. You cut it, catch hold of the sigmoid colon, bring it up either as an end or as a loop, and then we stitch it the colon with the anterior rectus sheath and the dermis. Okay, when you anastomose the dermis with the whole thickness bowel wall, we call it maturation of the stoma. Maturation of the stoma. Okay, so this is how you do colostomy. So colostomy is temporary, permanent, is done to relieve obstruction or done to protect anastomosis or done permanently after abdominoperineal resection. Okay, so these are the indications. What are the complications of colostomy one can have? See, colostomy what will it do? The effluent, the flatus and feces will be on the anterior abdominal wall. So there will be a little bit of irritation to the skin. Skin irritation. Skin irritation is much more when you do an ileostomy, because ileal effluents have got the fluid there, succus interriguus is very irritant to the skin. Colostomy effluent is not that irritant, but it's still some skin irritation can occur. Then the stoma can necrose. If you have not taken care of the vascularity, the stoma can become black and gangrenous. The stoma, if it is under tension, it can retract. Okay, so stoma can retract, it can stenose, it can become gangrenous. Sometimes, if too much of mucosa, it can prolapse outside. This stomal prolapse can occur. Sometimes prolapse can occur from the side if it is not tight fitting. It is called parastomal hernia can occur. Parastomal hernia can occur. Okay, so these are the usual complications. And in ileostomy, you can have fluid and electrolyte imbalance as well, which is not that common in the colostomy. See, the colon, the effluent will be thick, it will be fecal. In ileum, it will be thin, fluidy. Ileostomy is usually done in the right iliac fossa, whereas colostomy in the left or in the transverse colon. Okay. See, before doing colostomy, if you are doing as an elective procedure, as in abdominoperineal resection, or if after anastomosis you want to protect it, if it is a pre-planned anastomosis, then it is taken seriously, and usually a stoma nurse is there which marks the site where the stoma will be there, and you have to take into consideration that it should be away from bony prominences, scar marks, and it should fit the patient. Stoma is marked in a standing position, sitting and sleeping position, so that it should be above the cloth line, where the patient cloth line. It should be comfortable for the patient, okay, appropriate. It should not interfere with his daily work and clothing and all. So you have to mark the site properly. Usually it beside the stoma in such a way, if you are citing it on the right iliac fossa as an ileostomy, McBurney's point is a good point. It should come through the rectus abdominis muscle. Should be just lateral to the just medial to the lateral border of rectus. It should come through the rectus abdominis muscle. That will hold it properly. Same in the colostomy also. Okay, should be a bit higher at the junction of 2/3 and 1/3 line between anterior superior iliac spine and the umbilicus, coming just medial to the lateral border of rectus abdominis, properly stitched and vascularity taken care of. Okay, you put an appliance, bags comes over it, patient collects, the feces collects in that is emptied daily, and if bag gets soaked, broken or anything is there, spillage is there, then we change it, another bag is put. Okay, so the complications of a stoma, stomal obstruction, stomal necrosis, stoma retraction, prolapse, parastomal hernia, fluid and electrolyte balance, disbalance, and damage to the skin can occur. So this is all about colostomy. Thank you.